Hello and welcome to part 2 of 2 presentations on the shoulder. So we start with gleno-humeral joint dislocations and look at Hill-Sachs and Bony Bankart defects, scapula fractures, proximal humerus fractures, and then just have a quick look at the paediatric shoulder and also rotator cuff pathology.
The gleno-humeral joint is especially prone to dislocation. The reason being is that the shoulder has a very wide range of movement, and yet the actual articulation between the humeral head and the glenoid is very small, and this leaves it to be especially vulnerable to disruptions to the joint. An anterior dislocation is by far and away the most common dislocation and is seen in 95% of dislocations. It's usually caused by external rotation and abduction. Conversely, posterior dislocations are relatively rare. They're only seen in 2 to 4% of dislocations. Classically, it's caused by either a seizure or electrocution. However, in my experience, most are caused by a direct blow to the shoulder when the arm is extended and internally rotated. This is particularly common in rugby. Luxatio eretica is inferior dislocation of the gleno-humeral joint. It's extremely rare. It's caused by severe hyperabduction of the arm, with the neck of the humerus impinging on the acromion process. Let's have a look at these dislocations in more detail. In order to understand and recognise an anterior dislocation, you need to be able to recognise how it appears in the different views. On the AP view, the humeral head is anterior to the glenoid and inferior to the coracoid process. So therefore, on your image, the humeral head will be positioned towards the ribs. On the axial view, the humeral head is anterior to the glenoid, so it moves towards the coracoid process. Similarly, on the half-axial view, because the humeral head moves towards the coracoid process, it's positioned inferior to the glenoid. On the lateral view, the humeral head is anterior to the junction of the Y, therefore the humeral head appears towards the ribs. Okay, let's refresh our memory on what normal looks like. On our AP view, the medial border of the head of humerus overlaps the posterior border of the glenoid. However, the medial border of the humerus must not lie medial to the anterior border of the glenoid. On our Gracie view, the medial border of the humerus should not overlie the glenoid. The joint space should be between 0 to 6 millimeters. Okay, let's have a look at what's abnormal. Here we have an anterior dislocation of the gleno-humeral joint. So, here is the medial border of our head of humerus. It overlaps the posterior rim of the glenoid, but more importantly, it overlies the anterior rim of the glenoid, and the head of humerus lies inferior to the coracoid process. The head itself is moving towards the ribs. Therefore, this is an anterior dislocation. Look at the soft tissue. Can you see the squaring of the shoulder? That's the classic indication clinically that this is an anterior dislocation. So, what is it? It's dislocation. Where? Right gleno-humeral joint. How? Anterior. Okay, let's look at the anterior gleno-humeral dislocation on the lateral and axial views. So the lateral or Y view on the left, let's form our Y. So we form one strut from the acromion, one strut from the spinous scapula, one strut from the body of the scapula. We know that the glenoid sits at the centre of the Y, and the head of the humerus should overlap the glenoid. However, our glenoid is bare, and our head of humerus now lies inferior to the coracoid process and lies over the ribs. Therefore, the humeral head has moved anterior in relation to the gleno-humeral joint. Therefore, this is an anterior dislocation. Let's look at the axial view on the right. The axial views can be tricky to read, so let's identify our anatomy. Here's our clavicle. We know that our clavicle forms the acromioclavicular joint, therefore this must be our acromion. If this is our acromion, then this protuberance must be our coracoid process. This therefore must be our glenoid. The humeral head should sit on the glenoid. However, it's moved anterior towards the coracoid process and towards the ribs. Therefore, this is an anterior dislocation. So what is it? Dislocation. Where is it? Right gleno-humeral joint. How? Anterior. Dislocations are often associated with fractures. In particular, anterior dislocations are associated with a Hill-Sachs defect. A Hill-Sachs defect is a compression fracture to the posterolateral aspect of the head of humerus. Let's have a look at it on the AP view. On the AP view, we can see this very dense sclerotic line. It's on the lateral aspect of the humeral head, and this dense sclerotic line indicates the compression fracture. Now let's have a look at the axial view. As the head of humerus dislocates anteriorly, once it reaches maximum resistance from the shoulder joint capsule, the head of humerus is then retracted posteriorly against the glenoid. This compression of the posterolateral aspect of the humeral head results in the compression fracture caused by the glenoid impacting on the head of humerus. And this is our Hill-Sachs defect. Now let's look at this on the lateral view. So, our head of humerus has moved anteriorly in relation to the glenoid. As the head of humerus meets resistance from the shoulder joint capsule, the head of humerus is retracted forcefully onto the glenoid, so that the posterolateral aspect of the head of humerus impacts on the glenoid. We can see the head of humerus, which I've marked in red. The very dense sclerotic line is the compression fracture to the posterolateral aspect of the head of humerus, which is our Hill-Sachs defect. So, what is it? It's a fracture dislocation. Where is it? It's our right gleno-humeral joint. How is it? Anterior and compression, which is a Hill-Sachs defect. Let's look at our AP view and do our what, where, how. What is it? It's a fracture. Where? Left head of humerus. How? Compression. Hill-Sachs defect. Note that this is a post-reduction film. We know that because our medial border of a head of humerus overlies our posterior rim of the glenoid. However, it does not overlap the anterior rim of the glenoid. Therefore, this joint has been successfully reduced, and there is a normal gleno-humeral articulation. Sometimes dislocations can result in fractures to the inferior rim of the glenoid. This is referred to as a bony Bankart lesion. The reason why it's called a bony Bankart lesion is because you can get a Bankart lesion to the shoulder joint capsule, which is of course not visible on an X-ray. The bony Bankart lesion can often only be visualised on either a Gracie or an axial or half-axial view. It's frequently very difficult to visualise on an AP view. So, what is it? It's a fracture. Where? Right glenoid. How? Inferior. Bony Bankart lesion. Before we discuss a posterior gleno-humeral joint dislocation, let's quickly revise our Gracie view. On the Gracie view, we should be able to see complete superimposition of the posterior and anterior rim of the glenoid. The medial border of the head of humerus should lie between 0 to 6 mm lateral to the glenoid. That's a normal Gracie view. Posterior dislocations of the gleno-humeral joint are frequently missed. It's probably because most are actually subluxations rather than a dislocation. So what sort of signs can we see? On the AP view, because our humeral head is held in fixed internal rotation, we no longer see the greater tuberosity in profile. This means that the humeral head resembles a light bulb. On our Gracie view, normally the gleno-humeral joint space should be between 0 to 6 mm. The rim sign is when the joint space is greater than 6 mm. This indicates that the humeral head has moved posteriorly, creating diastasis to the joint space. On the Gracie view, we may get the half moon sign. This is where the humeral head overlaps the glenoid, but the important thing is there is no significant inframedial displacement. If you had marked inframedial displacement, then that would represent an anterior dislocation. So let's have a look at these radiographically. Let's have a look at this AP view. The greater tuberosity is no longer visualised because the arm is held in fixed internal rotation. Subsequently, the head of humerus now resembles a light bulb. Look at the joint space. The medial border of the head of humerus no longer superimposes the posterior rim of the glenoid. In fact, we can see complete space between the glenoid and the head of humerus. These signs indicate that there is a posterior dislocation. So, what is it? Dislocation. Where? Right gleno-humeral joint. How? Posterior. Now let's look at our Gracie view. We can see that the medial border of our head of humerus now superimposes our glenoid. This crescentic increase in density is meant to represent a half moon. This is our half moon sign. Importantly though, the head of humerus has not significantly displaced inframedially. If it had, then this would be associated with an anterior dislocation. So what is it? It's a dislocation. Where is it? Left gleno-humeral joint. How? Posterior. Posterior dislocations, like anterior dislocations, are often associated with compression fractures. These are referred to as reverse Hill-Sachs defects. To recap, a Hill-Sachs defect is a compression fracture to the posterolateral aspect of the humeral head. A reverse Hill-Sachs defect is a compression fracture to the anteromedial aspect of the humeral head. Let's have a look on the AP view. We can see that the head of humerus is held in internal rotation, creating a light bulb appearance. If we look carefully at the anterior aspect of the humeral head, we can see this dense sclerotic line, indicating the compression fracture. Now let's look at the axial view. Here is our clavicle. Here is our acromion, therefore this is our acromioclavicular joint. This protuberance then must be our coracoid process, and this is our glenoid. Therefore, our head of humerus has moved posteriorly from the glenoid. As the head of humerus meets resistance from the shoulder capsule, the head of humerus is then retracted back forcefully onto the anteromedial aspect of the humeral head, creating this compression fracture. So, what is it? It's a fracture dislocation. Where? Right gleno-humeral joint. How? Posterior reverse Hill-Sachs lesion. Here are the same images, but with a red line to indicate where the compression fracture is to help you identify the compression fracture. So what is it? It's a fracture dislocation. Where? Right gleno-humeral joint. How? Posterior reverse Hill-Sachs defect. Luxatio eretica, or inferior dislocation of the gleno-humeral joint. This is extremely rare, and it should be identified clinically, as the patient will present with severe hyperabduction of their arm, and they will probably be holding onto their head with their hand. We can see that the head of humerus is lying inferior to the glenoid and that the arm is hyperabducted. On this Garth's view, we can see the glenoid with the head of humerus pointing inferiorly. So, what is it? It's a dislocation. Where? Right gleno-humeral joint. How? Inferior. Luxatio eretica. true superior dislocation of the gleno-humeral joint is unbelievably rare. The most likely reason for the superior migration of the humeral head is due to a chronic tear to the rotator cuff. These are most frequently seen in patients over the age of 40. The insufficiency to the rotator cuff leads to the superior migration of the humeral head, and as the humeral head impinges upon the acromion, it erodes the acromion. In this particular instance, this patient has rheumatoid arthritis, and the rotator cuff tear is secondary to the chronic synovitis that has eroded the rotator cuff tendon. We can see that this patient has the hallmarks of rheumatoid arthritis, with concentric joint space narrowing, resorption of the distal clavicle, and whittling of the acromion. Therefore, when you see a superior subluxation, it's most likely due to rotator cuff insufficiency and must not be misconstrued as a traumatic process. Scapular fractures are frequently missed. They're caused by high energy trauma, of which 75% are caused in motor vehicle accidents. Of those, 80% are associated with further injuries to the head and thorax. It's these more significant injuries that distract attention away from the scapula, resulting in delayed diagnosis. The good news is, though, there's rarely any impairment to shoulder function despite distortion to the healed fracture. It's important when you identify a scapular fracture to look for rib fractures and a pneumothorax. And the most important thing to evaluate from a scapular fracture is whether there has been any involvement of the glenoid, as this will result in degenerative changes to the gleno-humeral joint long term. The AP and lateral view of this right scapula demonstrate a marked lytic line running along the spine of the scapula, indicating an undisplaced fracture. On our lateral, we can see a fracture through the base of the coracoid process, which is re-demonstrated on the AP view as a horizontal line that's slightly less lytic. Interestingly, the coracoclavicular ligaments have not distracted this fracture through the coracoid process. Don't mistake this as a mild superior subluxation of the acromioclavicular joint. Note that the clavicle is slightly rotated, which is creating a slightly false appearance of mild superior subluxation. Remember, for all scapular views, make sure you thoroughly check all your ribs and to assess to see if there's a pneumothorax. So let's do the what, where, how. What is it? It's a fracture. Where? Right scapular spine and coracoid process. How is it? Undisplaced. Proximal humeral fractures are biphasic. The first peak tends to occur around the second decade, whereas the second peak appears over the age of 45. These tend to be associated with osteoporotic fractures, and a proximal humeral fracture in patients over the age of 45 is similar to a Colles fracture in the wrist and a neck of femur fracture. Between 20 to 45, it's important to remember that proximal humeral fractures are uncommon and it's much more likely to be a gleno-humeral joint or a acromioclavicular joint dislocation. This is a comminuted fracture of the proximal humerus involving the greater tuberosity and the surgical neck. The head of humerus remains in articulation with the glenoid, so there's no dislocation. However, the surgical neck has significantly overlapped the head of humerus. So, what is it? It's a fracture. Where? Right proximal humerus. How? Comminuted and overlap. Another very common fracture to the proximal humerus is an undisplaced fracture to the greater tuberosity. These can be very subtle and are frequently overlooked. It's important to check carefully around the cortex to see if there are any tiny disruptions. What is it? It's a fracture. Where? Right greater tuberosity. How? Undisplaced. The shoulder joint is surrounded by a large, loose joint capsule. This means that if the patient sustains an intracapsular fracture, i.e. that the fracture occurs within the confines of the joint capsule, then blood and fat from the bone can extrude out into the joint capsule, creating a lipohemoarthrosis. With a lipohemoarthrosis in the shoulder, the fat, which is black, will be seen at the superior aspect of the shoulder joint capsule, and the blood rests below. It's important not to mistake an inferior dislocation of the humeral head in relation to the glenoid. What happens is that as the blood and fat fill up the joint capsule, it causes the head to become depressed with the weight of the fluid pushing down on it. This is referred to as a pseudo-subluxation. That's because once the blood and fat get resorbed within the shoulder joint, the humeral head will migrate back into the normal relationship with the glenoid. Therefore, it is not dislocated. It's important to know that this is a pseudo-subluxation because you don't want people to try to reduce the joint, which will only cause further damage to the patient's fracture. So, what is it? It's a fracture and a lipohemoarthrosis, where left anatomical neck and the greater tuberosity. How? It's impacted. The paediatric shoulder can perplex the unwary. Normal appearances are frequently mistaken for fractures, and it's all because of the numerous ossification centres. The humeral head forms at 6 months, with the greater tuberosity ossifying around about 1 to 2 years, and the lesser tuberosity ossifying at 4 to 5 years. The head, greater tuberosity and lesser tuberosity all fuse to form a single epiphysis at approximately 6 years. And these fuse with a diaphysis around about 18 to 20 years. The coracoid process physis fuses between 13 to 16 years, and you'll often see a coracoid physis at the short head of the biceps origin. The coracoclavicular ligament, apophyseal ossification centre, is demonstrated at 13 years. So let's look at these radiographically. The proximal humeral physis is demonstrated as two distinct lucent lines. The inferior lucent line in particular mustn't be mistaken for an undisplaced fracture, so you need to familiarise yourself with its normal appearance. The acromion ossification centre appears around about 14 to 16 years, and it fuses by 18 to 25 years. The coricoclavicular apophysis is demonstrated as a tiny sliver of bone on the medial aspect of the coracoid, and this appears at 13 years of age. Remember when I said that fractures of the clavicle in paediatrics, if undisplaced, tend to occur at the junction of where the clavicle overlaps the ribs. If we look here, we can see an undisplaced fracture through the clavicle. That's why it's important when you evaluate your shoulder joint to take care to look at this area in particular. The axial view on the left demonstrates the coracoid physis, which appears at the base of the coracoid process, and this fuses between the ages of 13 to 16 years of age. An additional physis is demonstrated at the short head of the biceps origin, and this too must not be misconstrued as a fracture. Proximal humeral fractures are biphasic, and in the paediatric, they are most likely to occur in the second decade of life. Fractures to the proximal humerus in the second decade are most likely to result in a slipped epiphysis. Strictly speaking, this patient demonstrates a fracture through the proximal metaphysis, which extends to the physis. Therefore, that's a type 2 Salter-Harris injury. However, we can see there's an associated slip through the physis, resulting in lateral displacement of the proximal humerus. Therefore, this is strictly a Salter-Harris 1 type 2 fracture. So, what is it? Salter-Harris 1 type 2 fracture, where right proximal humeral metaphysis. How? Lateral slip and overlap. Calcification within the rotator cuff is relatively common. However, not everybody with calcification deposits will be symptomatic, and it may well be an incidental finding. Usually the calcification is within the supraspinatus tendon. However, without ultrasound you cannot be certain. It used to be called calcific tendinitis, with itis meaning inflammation. However, this term is no longer used, as not everybody with calcific deposits will have inflammation of the rotator cuff, and therefore it is better to simply refer it as rotator cuff pathology. Do you remember the picture of the patient with rheumatoid arthritis? Here is another example of rotator cuff insufficiency causing superior migration of the humeral head, with the humeral head impinging upon the acromion. There's even a large subacromial spur, and this probably causes impingement to the patient. Remember, it's migration, it's not dislocation.